My name is Shweta Kapoor, and today I would be talking about propensity score matching, a statistical technique. So, I recently attended a lecture where they told us that whenever you're talking to an audience that you're unfamiliar to and who are unfamiliar to you, you should always start by telling them a little bit about your life and your journey. They said it helps with trust building, so I'm going to try that today. You've already heard that I have my first degree in physical therapy, and that is from India. That's where I originally am from. And then I moved to United States and did my master's at Penn State University. And I'm currently doing my PhD in human movement science with a concentration in epidemiological research, public health, and I have over 14 years of combined clinical and research experience. I've worked as a physical therapist in India and in the US. I have 13 peer-reviewed publications, one books, and I have presented at multiple platforms. And today I have this privilege of talking at this research webinar for Clcd Ghana. So thanks for that. So next, moving on to the background, before we get talking about propensity score matching, I would like to give you a little bit of background about why we need to do this and what's the purpose of propensity score matching. And to do that, let's think of a sample research question. Let's assume a very simple one in which we want to see the effect of a treatment, say X, on the outcome that is Y. So as you can see here, simply we want to see how X, which would be the independent variable, affects our outcome, or the dependent variable. But it's not that simple, as you probably know, because there is always a covariate or more that can act as a confounder, which is basically a variable that tries to affect both the dependent and the independent variable. And usually we don't just have one confounder, but many of those. So a little bit more about confounders. These are the variables that can distort or obscure the true relationship between our X and Y, which is the independent variable and the outcome. And different covariates can act as confounders, which means, we can have demographic factors such as age, gender, race, ethnicity, socioeconomic status, education level, marital status. Then we can have health behaviors like smoking status, alcohol consumption, diet, physical activity levels, medication adherence, and things like that that can act as confounders. And then we can also have clinical factors like the severity of the disease, any pre-existing comorbidities, medication use. We can have psychosocial factors such as stress, social support, mental health conditions, and coping mechanisms that can confound the results as well. Then also there could be environmental factors like pollution levels, climate condition, geographic location, access to healthcare facilities, etc., etc., etc. So basically, the list is too long about what covariates can act as confounders. It would depend on the kind of research you're doing, your research question, and in an ideal world, we have to control or adjust for all of these. So here I have a cartoon that kind of captures the gist of what an ideal world of research would be like, but at the same time, it also tells us how practical it actually may be or how impractical it would be for us to actually do that. So it says this is a randomized controlled trial, meaning that each of the two conjoined twins have been randomly assigned to a treatment group or a control group. So I can't see anyone's faces, but I'm assuming that you can see that what we want in an ideal world of research is actually sometimes very impossible to achieve. So that's when we start exploring at what else can we do to still get the results that we want and to still take care of all these factors that have the ability or that might be confounding our findings. So, to understand it a little more, let's talk about a research design that is considered a gold standard in research, which are the randomized controlled trials. So, in this, as you can see in this figure, we assume that we are getting or we are picking a random sample from the population at large, and then we randomly assign our sample or the individuals in our sample to one of the two groups. There could be different groups. For this illustration, we have mentioned a treatment group and a control group. So the individuals in our sample would be randomly assigned to either the treatment group or the control group. And now let's see what is the contrast between the randomized control trial and the observational studies. So in the observational studies, again, we have a population at large from which we randomly select a sample. But here, the sample is not randomly assigned to the treatment and the control group. So this is the basic difference just by the nature of the design of observational studies. You cannot randomly assign individuals into treatment or control groups or into the two groups that you're trying to compare. And as a result of this, observational studies are prone to selection bias. That is, what that basically means is that the individuals in the treatment group and those in the control group, they can vary from each other in systematic ways. And now I think would be a good time to also review the hierarchy of evidence in research. And you probably are familiar with this pyramid. We see it so many times. And as we move up this pyramid, the quality of evidence increases, but the risk of bias decreases. So at the bottom, you can see we're talking about animal and lab studies where humans are not involved. This is our basic science or bench research. And it's hard to generalize these findings to humans for obvious reasons. Then the next level are the case reports or the case series, narrative reviews, expert opinions, and editorials, which again have a low quality of evidence because there's a higher risk of bias depending upon which expert is writing that report or that editorial and what their background or line of belief or research is. Then we move on to observational studies, which are better than the case reports or editorials or narrative reviews, but they're still ranked lower than randomized controlled trials, which I mentioned and I showed you in the previous two slides. Why is that? And then as we move up, there's a meta-analysis, systematic review of randomized controlled trials, and at the top, there are the clinical practice guidelines. So my idea of reviewing this hierarchy of evidence pyramid with you today was kind of to form the basis of why we do propensity score matching. Because propensity score matching with this technique, what we are trying to do is that we are trying to take the findings of observational studies and get them as close as possible to the level of the evidence that RCTs actually provide or that randomized controlled trials provide. Okay, so now I'll begin talking about propensity score matching. This is a statistical method for addressing selection bias by creating a matched set of participants for treatment and controlled groups. So what we are trying to do is we are trying to take care of that selection bias that we saw is kind of inherent in observational studies. And we try to address it by making sure that we are matching the participants in the two groups that we have. So basically what we are trying to do is we are trying to get close to the quality of evidence or the causal inference that a RCT would actually provide us. Then if you're interested in this topic, I would suggest beginning with a classic paper by Rosenbaum and Rubin that they wrote in 1983, wherein they introduced this technique called propensity score matching. Now, what happened is that over the years, this method has gained popularity. But of course, there's certain groups of researcher that are happy with the traditional way of what we use to control for confounders or covariates that might be acting as confounders by using adjusted regression models or multivariable regression models wherein you control for all the confounders. However, some researchers prefer propensity score matching. They say it provides a better quality of evidence compared to the more traditional approach of the adjusted regression models. And then there are some researchers that like to go even a step further and they try to use a double robust approach, which basically combines the principles of these two techniques together when they analyze their data. So now moving on to propensity score matching. This picture basically illustrates what we do when we, perform propensity score matching. When you look at the picture on the left, you can see that in the rectangle on the top, they are illustrating the population with varying characteristics. There are circles of different colors and different sizes. Let's say the blue ones are the individuals that received treatment, and the gray ones are the individuals in the control group. With propensity score matching, what we aim to achieve is that we pick up each of the blue circles and we try to find a gray circle from the control group that matches this blue circle as closely as we can get it to match. And then if you look at the rectangle in the bottom, you can see that now we have kind of found uh, almost identical matches for each of the individuals or each of our observations in the treatment group. And we have matched them with at least one uh, observation or one individual from the control group. But another thing to note here is that when you do propensity score matching, you might not be able to find perfect matches for all of your observations or for all of the individuals in your sample. You might be left with some of the individuals that you couldn't match. So that is one drawback. You lose some of your data. And then the picture on the right is basically demonstrating the same thing, but in a slightly different way. If you like more colorful pictures, more vibrant one, then you can refer to this one. Here they have shown the subjects as ducks. So basically, you're trying to match each duck in the treatment group with a very similar duck in the non-treatment or the control group. Next, we move on to the steps that are involved in propensity score matching. So basically, the first step that we do would be your regular data collection. You collect your data after you've designed your study, you collect your data, you prepare it for analysis, and then after that is when you would estimate the propensity scores. And we'll talk more about each of these steps in the subsequent slides, but propensity scores are basically the probability or the propensity of each individual in the study receiving the treatment of interest based on their covariates. Then, after we have calculated these propensity scores, we move on to matching the individuals in the two groups that we have using these estimated scores. And I do see that there's a question in the chat. Okay, I don't think it's for me, so I'll move on. So we were talking about matching the individuals using estimated scores. And after we have matched the individuals and we have our matched cohort or the matched sample, before we proceed to analyzing it for the outcomes, we would evaluate the balance in the two groups to make sure that the two groups are very similar in the covariates that we want them to be balanced in. And the last step, finally, would be to analyze the outcomes between the two groups that we have achieved via propensity score matching and that we have evaluated using other statistical methods that they are completely balanced. Okay. Next, we would move on to more details about estimating propensity scores. So like I mentioned earlier, propensity scores are basically the probability of each individual in the study receiving the treatment of interest based on their covariates. So let's say we have a set of confounders, which are age, sex, severity of the disease, any pre-existing comorbidities. We would use all these confounders and then we would calculate what is the probability for each individual in our study for receiving the treatment of interest based on these set of covariates or based on these characteristics. So in more statistical terms, in order to calculate propensity scores, what the most common method that we use is logistic regression. And what we do is we do a logistic regression of the treatment condition on a vector of covariates. That is, we build a logistic regression model to see the probability of that individual with that given set of covariates or with those given baseline characteristics, their probability of receiving the treatment. So I know it's complicated. It took me a lot of time to understand this. So especially if this concept is new to you, all this might sound like Greek, but hopefully it'll get a little more clear as we move on and towards the end when I demonstrate it using an example. Next step in propensity score matching is matching the individuals or matching the observations. And so basically, what is done is we have calculated the propensity scores, and next we match the individuals in each group using these scores. Now, there are different techniques for propensity score matching. I will briefly go through all of these. It's a vast area in itself trying to figure out the right techniques, but I'll just touch upon all of these just so you're aware of these. So the first one is nearest neighbor matching technique. In this, you take a individual from group A and you match it to an individual from group B, which is the closest match in terms of propensity scores that you've calculated. The next technique is caliper matching. Here, you take an individual from your treatment group or group A and you match it to another individual from group B who lies within a certain range, and you pre-decide this range. Again, there's a lot of literature talking about what the ideal caliper for propensity score matching should be. The general consensus is that the caliper should be less than zero point 0.2 of the pool standard deviation. That's acceptable mostly. Then the next technique is radius matching. This technique is very similar to the caliper matching technique. However, in this case, you can match one individual from your treatment group, or let's say group A, to multiple individuals from your control group or group B. So radius matching does not result in 1:1 match. Multiple individuals can be matched to one individual from the other group. Next is a technique that combines the nearest neighbor matching to the caliper matching, and they came up with nearest neighbor matching within a specified caliper. So in this technique, basically what they do is they say, let's find a match that is closest to this individual in terms of propensity score match, but that match also has to be within the caliper that has been specified earlier. Then there are some other matching techniques like Mahalanobis and genetic matching. Again, I'm not familiar with these, and these are rarely used, so we'll skip them for today. Next, we move on to different algorithms that can be used. So we have talked about the techniques that can be used in propensity score matching. Next, we'll move on to the different ways we can use these techniques. And one of the ways is greedy matching. So this is the one wherein once the match is made, the matched units cannot be changed. Think of it like you're greedy, you just want a match to be made. And once the match is made, that those observations are like out of consideration. The next way is optimal matching. In here, even if one match has already been made, when you go to the next step of matching the next individual, the algorithm would still consider that previous match, and the aim here would be to ensure that you achieve minimal difference in the propensity scores of the matched individuals. So Stewart et al. In 2010, they proposed that if your idea for your research is just to obtain two groups that are well matched overall, then you can just use the greedy matching algorithm and you should be good. But if you want to achieve each pair, which is like the most well-matched pair that it can be, then you might have to use optimal matching algorithm. Little bit more on the algorithms. There are two different kinds again, which is one is with replacement, and then the next one is propensity score matching without replacement. So when you're talking without replacement, in this case, once a match is made, that observation is taken out of the data. So each control subject or each untreated subject can only be included once at the max in the matched sample. Whereas when you're doing propensity score matching with replacement, it allows the untreated subject to be included more than once. So the same untreated object can be present in your multiple matched sets that you achieve. Next, we move on to some of the assumptions of propensity score matching, and I've listed some of them here. The first one is the assumption of ignorability. Basically, what it means is that it's assumed that the treatment assignment is independent of the outcome. Of course, you don't want your independent variable to be influenced in any way by your outcome. And it also assumes that all the relevant confounding variables have been measured. Again, this is something that rarely happens, but we have to assume that we are doing it if we're doing propensity score matching. So this is also one of the limitations. Then is the assumption of common support. Basically, if you're trying to match individuals based on a certain score that's called propensity score match between the two groups, you want to make sure that there is overlaps in those scores. Because let's say if in my treatment group, all the individuals have very high probability of receiving treatment, but in my control groups, all the individuals have very low probability, then there's no way I can match them. So there has to be a common ground between the two groups. Next is the assumption of positivity, which means that all individuals in your sample should have a non-zero probability of receiving either treatment, like individuals, because if let's say you're looking for a treatment that is only available or only done or only given to females, obviously the males will have a zero probability of receiving that treatment. So you cannot include sex as a covariate in your model when you're calculating the propensity score. So with these, keeping these assumptions in mind, you have to be very careful about the covariates that you use in your model when you calculate the propensity scores. Lastly, we have the assumption of independence, which assumes that covariates that are used to calculate propensity scores, they should not be affected by the treatment itself. Next, moving on to the step of evaluating the quality of match. So once you've done the match, you have your individuals that are now matched with each others in the two matched groups. You have to check them to make sure that all the baseline characteristics are balanced. There you have to check that they have an equal distribution of all those confounding variables among group A and group B, or among the treated or the untreated groups. Now, if you do not see the balance, then you have to go back and reevaluate your strategies of how you calculated propensity scores, how you performed propensity score matching, because you might have to reevaluate uh, these things if your group is still not balanced. And once you have achieved two groups that are balanced, after you check them using different statistical tests, I've listed just a couple of them here. For post-matching comparison, you can, for continuous variables, you might be able to use t-test or Mann-Whitney test. For binary variables, you might be able to use chi-square tests, etc. Next, we move on to the final step of propensity score matching, which is analyzing the outcome. And So after doing all this hard work, statistically, you get to the final step wherein now you get to compare the two matched groups to see the association between your treatment or between the dependent variable that you're looking at and your outcome of interest. So you can run a regression model on the matched groups and see what you get. And these results would be considered, like I mentioned, a higher quality of evidence. There are instances when you cannot conduct randomized control trials, or you're pressed for time, or things like that. And that is when you can use these techniques to kind of increase the evidence, give more weightage to your findings, and make your findings more credible. Next is if you still have some unbalanced covariates, that's when you might consider using an approach that is called double robust approach, where what is done is that you use propensity score matching, but you also control for the variables that are still unbalanced. And this is called double robust approach. And then next, there's another technique that some researchers use, which is called propensity score adjustment, in which you run a regression model controlling for propensity score. Okay, well, like I said earlier, I am a physical therapist, and it is recommended that we break our posture every 30 minutes. We should have a chance to get up and move and stretch our muscles a little. So let's take a break for about 30 seconds, and feel free to just stretch your neck, do some upper body stretch, stand up, move if you need to, and be back in 30 seconds. Okay, I hope all of you have now had a chance to change your posture a little bit, move around and wiggle your muscles a little. So we will move on to the next slide now. So in this segment of the presentation, what I would do is that I would give you an example of how I used propensity score matching in one of my research work in a project that I did on COVID-19 patients. And the reason why I am choosing this research article is because this was the study that kind of introduced me to propensity score matching. That it was a lot of work, but I think it was worth it, because this manuscript or the study was published in Journal of Clinical Lipidology, which is a high impact journal, and it's the official journal of National Lipid Association of US. This study, the findings at that time were very relevant, and it got a lot of media attention. It was featured on the American College of Cardiology website. It was highlighted and discussed in the latest in cardiology section. It was also featured by JAMA, which is the Journal of American Medical Association, in their medical news and perspective section. An editorial on this study was written by the past chair of American College of Cardiology. So even though we worked very hard trying to learn propensity score matching and apply it, I can say it was worth it. So in this study, the paper is titled Association Between Antecedent Statin Use and Severe Disease Outcomes in COVID-19. And it was a retrospective observational study where we employed propensity score matching. So I'll just be discussing some aspects of this study, which would probably be relevant to the discussion we've had so far today. And the research question here, or the part of research question that I would be discussing today, was to determine the association between antecedent statin use and severe disease outcome. And today I'll just be discussing mortality among COVID-19 patients. If you're unaware with statins, these are the drugs that are used to lower your lipid levels. And antecedent statin use basically means the use of statins as like prior to the COVID-19 diagnosis. So we were looking at the patients who presented to the hospital with COVID-19, and then we collected their information. And what we did was we classified them into two groups based on whether they were using statins as home medication prior to their COVID diagnosis, or if they were not using statins prior to their COVID-19 diagnosis. And we collected retrospective data on more than 1,000 patients with confirmed COVID-19 diagnosis. And this slide, hopefully, I know the numbers are probably a little too small for you to read, but this is a slide that is showing you the baseline characteristics of the two groups that we had for our study. We have the statin group and the non-statin group. And as you can see here, the two groups are quite unbalanced. The groups, they differ in the age distribution, and they differ in the distribution in the burden of comorbidities. So the group that was using statins was older in age, and they also had a higher burden of comorbidities like pre-existing lung conditions, coronary artery disease, hypertension, diabetes, hyperlipidemia, chronic kidney disease, etc. And they also differed in the type of insurance they had. So to overcome this, of course, we used the traditional adjusting using a multivariable regression model, but then we went a step further and we also used propensity score matching. So this was done to obtain a 1:1 matched cohort. We used the nearest neighbor approach without replacement, and we used a caliper of 0.1. So we knew that we would probably lose a lot of individuals because we were trying to make matched sample which was as closely related in all the baseline characteristics as it could be achieved. And the propensity score for this study was defined as the predicted probability of the patients using statins within the patient's demographics, their BMI, their comorbidities, and all the other covariates that were found to be relevant for this population and this research design. And we conducted propensity score matching using SPSS. And the covariates that we used to calculate propensity score for this study included age, sex, race, BMI, the insurance, smoking status, comorbidities. We used all the relevant pre-existing comorbidities that at that time literature had shown to affect, both the use of statins as well as our outcome, which was mortality due to COVID-19. Next, we obtained a propensity score matched cohort. So after calculating and employing the strategy, the techniques that I listed in the previous slide, we obtained a balanced cohort of 466 patients. So as you can see, we began with like about 1,000 patients and we were down to 466. But that was okay because we already had the traditional regression analysis on the entire sample and we had the results and we were using this technique to kind of verify those results to see and to add more weight to our findings. So now we had 233 statin users and 233 statin non-users. But the point to note is that now these individuals or these groups were very similar in baseline characteristics for all the factors that we thought could be the confounders. Then the table here shows what we achieved. So we tested or we evaluated the balance between the two groups. And you can see in this table here that before matching, we had such an unbalanced group, but after propensity score matching, our group was quite balanced now. And like my little one says, green light means go. So these green arrows indicated to us that we were good to go and proceed further to analyzing the final outcome. And when we analyzed the final outcome, we used a binary logistic regression, which was conducted on the propensity score matched cohort for the outcome, which was mortality. And we found a significant association between the use of statins prior to the COVID diagnosis and reduced mortality. So what we found was that those patients who were using these medications before they got infected with COVID-19, they had reduced mortalities. And these findings were very relevant at that time in the pandemic because we didn't have a treatment, and like a solid evidence for a treatment. And using results of this study and other studies, many randomized controlled trials were then started wherein they tried to, employ those randomized controlled trial designs to see if the statins would have an effect or not. And then the results, we also showed that we got similar results of reduced mortalities using both the traditional adjustment via multivariable regression model as well as using the propensity score matching technique. Okay, with that, I am all set. These are some of the references if you're interested in knowing more about this topic. And this is the QR code if you want to read the entire article and read more about how propensity score matching was used in our paper. You can scan this. And I'm ready to take any questions if you have.
All right, thank you very much, Shota, for the presentation. So if you have any question, you can raise your hand or you can also type it in the chat box. So whilst they are preparing their questions, I wanted to ask, is it really important to do propensity score matching?
I'm sorry,
Is it
can you repeat
important to
that?
do it? Is it important to do it? What's the significance of doing propensity
So,
score matching?
like I said, there is a group like there's a lot of literature where they're trying to see if how, because one method that is very widely used is just to control for those confounders using a multivariable regression model. But this is another statistical technique which if one, it's hard to say that one is superior to another, but there is some literature that says that propensity score matching is superior to the other traditional technique in which you just adjust for the confounders or the variables that might be affecting your findings. Whereas there is some literature that suggests that, oh, this is just another technique. So it depends on whom you're talking to. You might find a reviewer who insists on doing a technique like this before they can find your findings credible. And this another thing is that when you're able, in absence of any randomized controlled trials, if you're able to use this technique along with the traditional technique, it adds a lot of weight to your findings.
Okay.
The belief is that if your findings if you're finding something using this technique and using the traditional methods, it's highly likely that you would probably see those findings in the randomized control trials as well.
Okay.
But of course, there are limitations.
Okay. Thank you. So Robinson has a question. You can ask your question.
Right. Thank you very much for your presentation.
Thank you, Robinson.
Yeah, my research is on the randomized control trial, how to improve the quality of life for individuals with cerebral palsy. And the question I want to ask is, what is the minimum size can you adapt for the propensity score? And also, is it only randomized control trial that you can use to conduct?
No.
Yeah.
So actually, if you already are doing a randomized control trial, you don't need to use propensity score matching, because this is a technique is that is usually employed for observational studies, wherein you cannot do that random selection of subjects into the two groups. Because in randomized control trial, you can already, just by the design of your randomized control trial, you can take care of the selection bias.
Okay.
So you don't have to use it, but of course, if I have seen people using traditional controlling for co-confounders, if they find that even despite of randomized design of their study, their groups are still not balanced for some reason, then it might be something to consider. But yes, traditionally, it is more useful for observational studies.
Okay. Okay.
Sure.
So with the observational studies, what is the limited or the minimum size of population?
Oh, for population, there I haven't found any literature that specifies that you need to have at least so many individuals. But just by the design, that you would lose some of the data. So it's more appropriate for like larger sample sizes. So if you're talking at least a few hundreds, it might then propensity score matching would be something to consider. But if you only have a research study where your sample size is 10 in each group, and then you go on to propensity score matching, and you can only match like 6 individuals, so that is like drastically cutting down your sample size, and then your study might not have enough power. So it's
Okay.
more
Thank you very much.
useful for larger, yes.
All right. Thank you very
You're
much.
most welcome.
Yeah. So I think because this is a new technique, it sounds a little bit complicated as well. Do you think we could perhaps do it a little bit more practical, maybe like do the regression analysis, and then you take us through the steps to do the propensity score matching? I mean, not today.
Oh, yeah, that would have to be another long presentation in itself. I wish it was that quick and easy and I could just show it, but yeah.
Okay, so Napoleon, you can ask your question.
Yes, I want to find out, let's say you using intervention like breastfeeding on children, and with that you want to know whether if you give the children breast milk within 6 months, and then those that they will not be giving breast milk within 6 months, you collect data on that, and you want to do this propensity matching. The matching would exactly be on what? That's my question.
So the matching is exactly based on the variables which you think might act as confounders. And I kind of assumed that most of you have an idea about what confounders are, but I tried to touch upon it a little bit. So these are the factors, that might affect or that might modify the effect of our variable on the outcome. So let's say we are trying to, like in your case, you're trying to say your hypothesis is that the depression or the maternal depression would affect the amount of feed that the baby is getting. So you're basically just seeing that, in this case, your outcome is the amount of feed that the baby would get, and your independent variable is whether or not the mother has depression. But there could be so many other factors, in the real world that could impact it. It could be the amount of social support that she has. So that would be one confounder, because that could affect the the maternal depression, and that could also affect the amount of feed the baby is getting within the first 6 months. So you have to think of all these confounders, and your propensity scores are actually based on this.
Can I come in here? Can I come in?
Sure.
Okay. Who asked the question? Just the one you just responded to. Who asked?
Sure.
Was it Napo that asked?
Yes.
Okay, fine.
Yes, Napoleon.
Okay, let me give a simple scenario. Okay, let's say we want to find out let's say student academic performance and study habits. Okay, its effects, and we all know that when it comes to student academic performance, it is not only study habits that influence student academic performance. There are a lot of factors that influence student academic performance. Okay, so our duty with the propensity scoring is to identify other factors that may have an indirect effect to the results. If you have to look at the impact, that is students' performance and study habits directly, you would realize that certain factors also influence the student's academic performance, not necessarily the study habits alone. It could be the eating habits, it could be time of learning, it could be sleeping habits. So we have to find these factors, and we call them in statistics, we call them the control variables or control groups. Okay, so we have to covariate them. When you covariate these variables, then you can now find the direct propensity effect of study habits on the student's academic performance. Otherwise, you run your analysis and you realize that, yes, there is an impact, but you would not be able to tell us the amount of impact because of other factors you didn't look out for. So your duty is to look out for other factors that may have an indirect effect on your results, and you just covariate them or you hold them constant. Thank you.
Yes, you're absolutely right. The factors that you're referring to, control variables, are the factors that I was referring to as confounders. They are the same thing. And this technique is another technique, just like how in regression model you control for these variables. So this is the propensity score matching is a technique that some people consider is superior to that regression technique that is used to do exactly the same thing, is to control for those variables that might be affecting your results.
Okay, so if that is the case, then what is the difference between this propensity score matching and structural equation model?
So they are just two very different statistical techniques. It's yeah, I'm not an expert in structural equation modeling, so I can't say much about it. But
let me come in here with a structural equation model. Okay, that one, it's more or less like you are running let's say trying to create a model out of certain factors. Let me give you an example. You want to create a model, let's say, you know how to run a multiple regression, right? So the models that are derived from the multiple regression, just like the structural equation model. And that one we use more of the time, we use the starter, okay, to run such analysis. You see, when you are using SPSS, then what you have to do is run the multiple regression. And out of the multiple regression, you'll be able to identify the R square and the R square change, okay? Then the R square change will give us the individual contributors of the factors, which is the predictors, okay? Now, these predictors are used to develop the model. So we have the structured model and you have the unstructured models. So the unstructured models are models that have errors. We call them constants, okay? Constants within them. And the structured models do not have constants, okay? They are more or less the beta weight or the beta alpha, okay? So at the end of the day, you will get to understand that with the structural model, since it is not having a constant in the beta alpha, we then believe more of their impact or their results than the unstructured model. And more or less, they have that partial eta square, which actually contributes the amount of effects, okay, of the predictors on the criterion. And the criterion here is the dependent variable, and the predictors is the independent variables that you are using in your study. However, the structural equation model and propensity scoring are quite two different things, okay? They are quite two different things. With the structural equation model, you do not have that to hold certain factors that may influence your results. You do not have that influence to hold them, but you just need to find out what are my dependent variables and what are my independent variables in my study. Probably just go straight to that with the structural equation model. But with the propensity scoring, you, the researcher, has to find out from literature what other factors can actually influence my results. Then you can then hold these factors constant. It is more practical because I always tell my students here in Ghana that when you are running such an analysis, in your question, you should be able to move certain variables from literature constant. You measure them. When you measure them, you can covariate them in your analysis. But with the structural equation model, it is not a necessity to hold them constant. You only identify your independent variables, in this case, your predictors. Then you just run your analysis and you're able to derive your models from it. So they are quite two different statistical techniques. Thank you.
All right, thank you very much, Justice, for your submissions. There's a question from Cynthia. I think we can answer that and then we'll bring the webinar to an end. She's asking, which study designs would you recommend the use of propensity score matching?
So mostly it is for observational studies, which would be your cohort studies and your case control studies. I have all the times when I use propensity score matching, I've used it for retrospective cohort studies. So primarily observational.
Okay, thank you very much, Shweta, for the presentation.
All right, noted. Thank you very much.
Thank you. Thank you.
Okay, so thank you very much for your time. And thank you everyone also for joining today's webinar. So we'll be having the next one next month. I will send you the recording of today's lecture. And I'm sure because it's a new technique for a lot of us, you may have to go to the recording and then go through the slides so that you can take some time to understand the assumptions and everything, so that you can use it and see how it will help you in your research. So thank you very much for joining us. We'll end here today. and I'll send you the recording. And next month we'll come here again for the next webinar. All right, so bye everyone.
Thank you.
Thank you very much. It's been a rich experience.
Thanks
Bye.
so much.
You to the presenter. Bye.
Thank you.
Thank you very much.